Hi, Chapter 6 is entitled The Central Venous Pressure. And once again, I'm Dr. John Emil Kenny. So the central venous pressure, let's get started here. So as I hope you appreciate at this point in your training, the central venous pressure is a hemodynamic variable of multiple covariant determinants. And unfortunately, the physiology of the CVP is frequently misunderstood, and as a result, people demand of the CVP things that it actually cannot tell you, things like volume status, how hyper or hypovolemic a patient is, and also volume responsiveness, that is whether or not somebody will respond to a fluid bolus by increasing the cardiac output. Frankly, asking these of the CVP, if you understand the physiology, is a bit absurd. And I think appreciation of the physiology of the CVP, its determinants, will give the clinician a much more informed approach to the central venous pressure as a value and its trend with time. So this chapter will be broken down into basically 4 parts. The first part will be focus on principles of measurement of the CVP, which I think are also often forgotten. And then I'll talk about the determination of the CVP, rather the physiological determinants, and I will make very clear distinctions between the central venous pressure, volume status, and volume responsiveness, because they are very different things. And then I'll use that as a jumping off point for the use of dynamic assessments of the CVP, which are a little bit better at actually determining volume responsiveness than the simple static one-time number of the CVP, and also use it as a basis for the discussion of the ultrasonographic assessment of the inferior vena cava, which is becoming exquisitely popular, especially at Stanford with these house staff with their pocket ultrasound devices. So let's talk about the basics of measurement. So these are 2 beakers. Let's say they're full of water. Let's say that they are both 20 centimeters in height. And so on the left here, I've placed a little manometer, and it appropriately reads 20 centimeters of water, and that's because there's 20 centimeters of water above the level of the transducer, and that's the pressure that's exerted at that level. And I'm using this as a demonstration of the importance of where the transducer is placed in relation to the fluid-filled container that you're trying to measure. In our case, we're interested in the pressure in the right atrium, and in this case, we're interested in the pressure that the water is exerting on this beaker. So then on the right, we've changed the reference point, and now it's 10 centimeters above this level, 10 centimeters above this level, and it only reads 10 centimeters, and that's because it's in reference to the height of the column of water above the area of the transducer. And this is important in patients because patients in the ICU the bed moves up and down, and actually the transducer, where it's placed, usually on an IV pole just adjacent to the patient, it moves up and down, and so this will alter your pressure measurements, and it's based simply on gravitational changes. What's also very important when considering the level of the transducer is that this principle applies even when a fluid-filled catheter is used as the measuring device. And equally important is that the length of this catheter here and the length of this catheter here are irrelevant to the pressure measurement. So this catheter could go way up here and come down, and it would still read 10 centimeters of water. And so what is the clinical relevance of that? Well, it doesn't matter how long your triple lumen catheter is. So not all triple lumen catheters are the same length. There's some that people use to place left IJs, and they're a little bit longer than triple lumens that are placed in the right IJ. It also means that the length of tubing that a nurse uses to connect the triple lumen on the port outside of the patient, the tubing that then goes to the transducer, the length of that is irrelevant. It may dampen the waveform, but the length does not matter as long as this transducer is in the same three-dimensional space in reference to the patient. Also, well, or I should say that this physiology is how, if you don't believe me, this physiology is how we measure a wedge pressure. And we're going to talk a little bit more about this in chapter 7, but think about how we measure a wedge pressure. It's a pressure that's measured off of a very long catheter that is wedged inside of a pulmonary artery. And then beyond the length of that very long plastic catheter, when the balloon goes up, it creates an even longer column of static blood that goes to the left atrium, and from that we measure the pressure. And so you can apply the same reasoning to a PICC line. As long as it's a static column of water, it doesn't matter. The waveform may be dampened a little bit, but as long as it's the positioning of the transducer to the patient is unchanged, the pressure will be the same. And so I've encountered some cardiologists who believe in the sanctity of the wedge pressure, but if you tell them that you've transduced a CVP off of a PICC line, they look at you like you earned your medical degree online. And believing in the physiology of measuring a wedge pressure, but not believing in the physiology of transducing a CVP off of a PICC line is not intellectually consistent. And indeed, interestingly, this was studied in a journal article where 10 cardiologists were posed this physiological conundrum, and all 10 of them got the question incorrect, but you will not. Just give me a moment to put down my bullhorn and step down off of my soapbox, and we will move on. So just sort of a clinical correlation here. This scenario would be similar to lowering the transducer or raising the patient relative to the transducer, and conversely this would be like raising the transducer or lowering the patient relative to the transducer. You can see that this scenario will lower the CVP and this scenario will raise the CVP. Okay, so after all of that, what is the point of reference? Well, it should be 5 centimeters below the angle of Louis or the sternal angle. That's pretty consistent amongst all patients. And fortunately for us, that position of the right atrium relative to the angle of Louis doesn't change even when the patient is head up tilted a little bit for nursing care or for the prevention of ventilator-associated pneumonias. This is not true. This measurement does not hold true if the mid-axillary line at the point of the sternal angle is used as the reference point. When that is used, which I see often in the ICU as sort of like a zeroing point, when the patient's head is up, that is completely incorrect. That reference point is only valid when the patient is supine. And when the patient has the mid-axillary line used as the reference point, the measured CVP actually tends to be on the order of 3 millimeters of mercury higher than the reference point 5 centimeters below the angle of Louis. Excuse me. So once the transducer is placed at an appropriate three-dimensional level, or relative to the patient, it must then be zeroed. And that's similar in principle to the tare weight, like when you go to the grocery store and you want to buy some almonds and you have to place it on a scale. You put your container on the scale. You don't want to pay for the container, so you then tare the weight, make it zero, and then you buy your almond. You pour your almonds in afterwards. It's the same thing here. And we for simplicity, we make this zero level atmospheric pressure, and that's just because that's easy to do rather than, say, referencing it to pleural pressure, because that would require another measuring device. And you can think of the importance of making atmospheric pressure zero when you consider what your blood pressure would be in outer space. So a normal systolic blood pressure relative to no atmosphere, that is relative to outer space, you'd have a systolic blood pressure of 880 milligrams of mercury, and that's actually what your true distending pressure is at sea level as well, but you have to realize that 760 millimeters of mercury, that is actually a result of ambient atmospheric pressure. So your systolic blood pressure is actually 120 millimeters of mercury above atmospheric pressure. And that's why I think if you were exposed to outer space without a protective suit, then like horrible physiological things would happen to you. And so it's very important to realize that the zeroing to atmosphere introduces a measurement artifact, and that artifact is because the right atrium is within the thorax, and the thorax is not atmospheric. It's actually subatmospheric even at FRC, and you can see that, we talk about that in chapter 1. And then during a spontaneous inspiratory effort, the ambient pressure, the pleural pressure, actually goes down even further, goes down below atmospheric pressure, and you actually measure that in your CVP tracing, but it introduces this artifact thinking that pressure in the right atrium is actually going down, which may imply that filling is going down in the right atrium, but that is actually not correct. And this is a cartoon to show you why. So this is your, let's say this is your mean systemic pressure in your abdomen, and this is your IVC, and this is a cartoon of your right atrium, and we can just pretend that the heart is in behind it so we don't see the rest of the heart. And this is the thoracic cavity, the pleural pressure. So what happens when pleural pressure goes down, like the onset of an inspiration? Well, if you were to measure the pleural pressure relative to atmosphere is on the outside, you would measure this blip, and that blip is pressure going down in the pleural space relative to atmosphere. I think we all appreciate that. But instantaneously, as the pleural pressure goes down, right atrial pressure goes down as well, because it's a thin-walled compliant structure, so it tends to track the decrease in pleural pressure. But, this is the important, but with the decrease in right atrial pressure, you have an instantaneous influx of blood from the mean systemic system, from the mean systemic pressure head. And so that increase in volume actually keeps the pressure in the right atrium a little bit higher than the pleural pressure. So this pressure is going down relative to atmospheric pressure, but because of this influx of blood, the pressure goes down not quite as much, comparing the two. So this is a catheter. This is essentially your CVP. You're measuring the pressure in the right atrium relative to atmosphere, but you can see that there's a difference between these two. This pressure is staying lower than this pressure. And then so if you had a magical catheter that referenced right atrial pressure to pleural pressure, the pressure is actually going up. The pressure in the right atrium is staying higher and going higher than the pleural pressure during an inspiratory breath, and that is your transmural pressure. That's the pressure within a distensible object, less the ambient pressure. And the increasing transmural pressure, as we talked about in chapter 2, is a vascular pressure. The transmural pressure is what determines volume. It's a static pressure. It's what determines volume of distensible objects. And the increase in transmural pressure means that the volume tends to increase, and the degree to which the volume increases, as we know, is modulated by the compliance of the structure. This is also the reason why vascular filling pressure should always be measured at end expiration, and the reason is that at end expiration, this is the closest you're going to be to atmospheric pressure. Because the reference is atmospheric pressure, you want to know what that pressure is relative to atmosphere, and that will give you your true, or as close to your true, transmural distending pressure as possible. It becomes completely erroneous to measure that during an inspiratory cycle. Important caveat to that is that this can be very difficult during forced expiration. And this is common in the ICU, even in tubed patients, is that as patients bear down and grunt and force an expiration out, their pleural pressure will rise during expiration, and then you actually have absolutely no reference point, and trying to estimate a true transmural or a true vascular distending pressure in that situation essentially becomes impossible. Excuse me. So this is your little ICU monitor. We're going to talk about what we see here. So let's focus in on one of these Pqrst complexes of the EKG, and we all know what these represent from first year medical school. But we'll do the same for a single cardiac cycle for the CVP. And if you walk up close to the ICU monitor, you'll see these undulating waves of the CVP, and you'll often see a number next to the CVP, which is a computer-based average assessment, usually from the highest point to the lowest point. So it's kind of a garbage number, even though I see it used as the definitive CVP in ICU patients all the time. Let's focus in on this cardiac cycle here and talk about the waveforms. So the first of the 3 positive deflections, okay, there's tends to be 3 positive deflections of the CVP and 2 negative deflections. The first is the A wave, and this is determined by, these are temporally in sequence here, atrial contraction. And electrical conduction precedes, usually by milliseconds, the pressure conduction within the cardiac cycle. So this is the increase in pressure in the right atrium as a result of the right atrial contraction, and the height of this pressure wave is dependent upon the strength of contraction, the volume transferred, the compliance of the atrium at the time, which is volume dependent. So at very high atrial volumes, actually, compliance is low, so for a given volume, pressures will be higher, and that can become important in patients who are overloaded. Often you'll see these waveforms most pronounced in patients who are wildly fluid overloaded, and if you picture their atria just massively distended, poorly compliant because of the massive distension, then that poor compliance is going to make the pressure changes even more pronounced, so you'll often see all these waveforms in overloaded patients. So because it follows the atrial contraction, the A wave is absent in AFib. It's flying along at a rate of 300 in atrial flutter. And if it's contracting against a closed tricuspid valve, i.e. you are in a state of atrioventricular dissociation, you'll see very high A waves, and we call these cannon A waves, and you'll typically see that in conjunction with a low cardiac output beat. So if you have an A line in the patient, you'll see the cannon A wave, and that will correspond with that beat with a low systolic pressure because the output is lower as you've lost your atrial filling. So this fills the ventricle at very end diastole. It kind of packs the right ventricle to the brim just prior to the onset of systole. And then at this point here, the tricuspid valve closes and you get isovolumic contraction in the right ventricle, and that's discussed in chapter 2. And then this blip, the second positive deflection of the CVP, which you may not see because it can be below the limit of detection on many CVP monitors, is the C wave, and this is essentially just the billowing or the bowing of the tricuspid valve backwards into the right atrium during systole, and this occurs even when your tricuspid valve is totally competent, and it's just, you can sort of picture the valve tensing backwards like a parachute opening during systole. So the important thing is that the A wave marks the end of diastole, and so the C wave marks the beginning of systole. So end diastole is actually this little valley here, and we call that the Z point, or for my friends in the True North Strong and Free, we would call this the Z point, and this is end diastole. So this is actually here your end diastolic filling pressure. This is really the true filling pressure of the heart that you want to know, again, at end expiration. So if you wanted to measure a true CVP, you would wait for this undulation to signify end expiration, and then at that point at end expiration you'd look for the Z point, or conversely you could freeze the monitor and correlate that with the onset of the QRS, because that's the onset of systole, and that would represent your true CVP, your true vascular distending pressure prior to the onset of systole. Following the C wave, as systole progresses, you can imagine the right ventricle during systole, the papillary muscles are contracting and actually pulling the tricuspid annulus downwards, and the pulling of the tricuspid annulus downwards actually increases the capacitance of the right atrium and lowers the pressure. And the lowering of the pressure is the X descent. You can sort of picture that like a piston pulling down. The pressure above the piston would then drop, and that's going to represent your X descent in the right atrium. But filling continues throughout systole of the right atrium, and so then pressure begins to rise again till you get to the very point of the third positive deflection. This is the first negative deflection. The third positive deflection is the V wave, and at the very pinnacle of the V wave, this is when pressure in the right atrium supersedes right ventricular pressure, and when the pressure in the atrium is above that of ventricular pressure, and this occurs at end systole after the stroke volume has been ejected, then the tricuspid valve opens, and then you have the Y descent, and that's the drop in pressure as the tricuspid valve opens. So the V wave, you can imagine, you'd expect it to be very tall and abrupt if you had an incompetent or leaky tricuspid valve. We call these tall V waves. The moving on to the Y descent, a large Y descent represents a large pressure gradient between the right atrium and the right ventricle during the onset of diastole, and you can get that. You can see that in restrictive filling defects, because if the right atrium, if it's like a constricted pericarditis and the right atrium is very constricted, that its pressure will go very high, and it will fill at a very high pressure at end systole. And then as the tricuspid valve opens, that high pressure in the right atrium compared to the low pressure in the right ventricle will lead to a very pronounced Y descent. That's in contrast to true or classical textbook cardiac tamponade, and this is what we call coupled pericardial restraint, and it's coupled because all of the chambers of the heart are being exposed to the same high pressure fluid, that is the pericardial fluid, and that's when all the pressures within the chambers begin to equalize during diastole. And in true kind of classic textbook coupled pericardial tamponade, you lose the Y descent as the pressures equalize between the two chambers at end systole. And this reasoning falls apart when you can actually have a kind of pericardial tamponade known as uncoupled pericardial restraint, and that's if you have a loculated clot or a loculated fluid pocket around, say, in and around the right atrium. So actually it can mimic restrictive filling, where you can have a very high right atrial pressure and a low end systolic ventricular pressure, so you maintain your Y descent during a loculated kind of pericardial tamponade. So the presence of a Y descent does not rule out tamponade. The presence of a Y descent does rule out the textbook tamponade, where the entire heart is surrounded by a high pressure fluid. All right, I talked too much about the CVP tracings already, so what do I want to talk about now? So the deflection, the true CVP, the true end diastolic pressure we talked about, it corresponds with the onset of the QRS. So this portion here is systole. So remember, systole ends at the apex or the pinnacle of the V wave, and it begins at the Z point. And so during systole, this is where you would see tricuspid regurgs in the tall V waves. So that's everything that I wanted to say about principles of measurement of the central venous pressure. In the next excerpt, we're going to talk about what the CVP is and what determines it. Thanks.